Hello to everyone. I am Sarah Ramaya, Curriculum Specialist at ASRM. Welcome to this webinar on How Old is Too Old for Art? Making Ethical Decisions in Reproductive Care. Please join me in welcoming my colleagues Jessica Goldstein and today's moderator, Dr. Sigal Klipstein. Before we begin, please note, this webinar was developed by the American Society for Reproductive Medicine as an educational resource and service to its members and other reproductive professionals. While this webinar reflects the views of its panelists, it is not intended to be the only approved standard of practice or to dictate an exclusive course of treatment. Members should always use their best judgment in determining a course of action and be guided by the needs of the individual patient, available resources, and institutional or clinical practice limitations. All attendees will be muted except the presenters. Time at the end of the presentation will be reserved for questions. Please type a question in the question chat window at any time. We will read as many selected questions as possible to the presenters during the allotted question and answer time. A recording of this webinar will be archived on the ASRM website in the coming weeks. Please watch your email for notification. I will now turn the presentation over to Dr. Klipstein to introduce today's speakers. But before that, I'd like to introduce our moderator. Dr. Klipstein practices reproductive endocrinology and infertility at INVIA Fertility Specialists in Chicago and is also an assistant professor at the University of Chicago. She is the chair-elect of the American Society for Reproductive Medicine Ethics Committee. Dr. Klipstein.
Thank you so much. I'm so pleased to welcome all of you to today's webinar entitled, How Old is Too Old for ART? What's an Ethical Clinician to Do? We have quite the panel of experts, each with extensive experience in caring for individuals of advanced reproductive age, each from their own unique perspective. We'll hear from the point of view of a reproductive endocrinologist, an expert in maternal fetal medicine, and a clinical psychologist. Historically, reproduction was limited to sex in the bedroom, and we've really come a long way from that point. The ability to utilize egg donation and the incorporation of gestational carriers has allowed us to allow for reproduction essentially at any age. So I ask us to consider the following question as we hear the speaker's presentations. There's no longer a true scientific, or perhaps better said biological, limit to the upper age of reproduction. However, just because we can accomplish reproduction at any age, should we? And if we agree that limits should be placed on reproduction at advanced ages, how are these to be set? Who should set them? And how should such impactful decisions be made? And with that, I'd like to introduce our first speaker who was involved with egg donation from its earliest days. Dr. Mark Sauer is a clinician, researcher, and medical educator best known for his work in the development of egg and embryo donation, fertility care of HIV seropositive patients, and reproductive bioethics. He is currently Professor and Chair of Obstetrics, Gynecology, and Reproductive Sciences at Rutgers Robert Wood Johnson Medical School in New Brunswick, New Jersey, where he also serves as the Senior Associate Dean for Women's Health. Dr. Sauer was the former Chief of the Division of Reproductive Endocrinology at Columbia University Medical Center, New York, and served on the Medical Ethics Committee of New York Presbyterian Columbia University Medical Center. And with that, I'd like to introduce Dr. Sauer. Looking forward to your talk.
Thank you, Dr. Klipstein. And thank all of you in attendance tonight. It looks like we're up to about 177 participants, which is a nice turnout, especially at this time of the day. So we'll start my disclosure, as you can see listed, and there's no conflicts in my opinion. So why are we here tonight? Good question for everybody. It's interesting for me, particularly because I spent pretty much my entire professional life dealing with this age of how old is too old. And I can honestly tell you, after 30 years, the questions remain unanswered, and they're really hotly debated. Going back to some of the early work I did at USC in the 1990s, it was pretty obvious once we started extending care to women after menopause, we were seeing some public backlash, and the pundits and the comics were everywhere, including magazine covers for that matter. But it always seemed unfair to me because the patients I was caring for were certainly nothing like these women depicted here. They were really vibrant, active women who, to me, was very understandable as why they were asking to have children despite their advanced reproductive age. And this debate continues. I was watching television just the other night. Anderson Cooper came on to announce the birth of his son at the age of 53. And again, there's a lot of celebration around these events. I felt very, very happy for him. I think he'll be a great father. but there's also a lot of public condemnation for these things. So this is no longer even a gender issue. It affects both men and women these days who are having children. What was particularly interesting about Anderson Cooper's story to me was that not very long ago, when interviewed discussing the early death of his father at the age of 50 when he was only 10, how profoundly impactful it was. And as you can see from a quote from this interview, the world suddenly seemed a much different place after his father's death, and more ominous, more dangerous, right? So we do need to take into account this issue of longevity when we're so focused on natality and trying to help a woman have a baby. Most of these issues, and this is the primary focus of tonight, is related to medical ethics. There's so many issues in play here: respect for autonomy, that of the patient, but also that of the physician and the caretakers, the right to choose, and the right to refuse, for that matter, extending care. They have to do with reproductive rights and freedoms. We tend to have focused on the benefit, especially to the patient herself or the family themselves, when they have the celebrated birth of a baby that in the past would have been considered impossible to bear. But we also now certainly need to be thinking about the long-term consequences of these actions, particularly with the third principle of do no harm. We have a mother to think about, a child, a family, and society as well, who have a stake in these outcomes that should be discussed with the patient as part of the informed consent process and the decision whether or not to proceed. And then lastly, justice, of course, free access to care or to deny care, and recognize that there's prejudice in play here that related to ageism and sexism. Interestingly, when I went back to look at things that I had written back in the USC days, Rick Paulson and I, we were much younger there, as you can see. For those that know us now, we've gotten a little grayer, a little more worn. But we were pretty spot on in most of the decisions that were governing our actions. They were very much thought out. It wasn't just a matter of sensation and making people pregnant. It was the then whats that go with it. So we recognized that this new emerging technology of egg donation particularly was going to make pregnancy possible at any age. And in thinking about that, we decided that restrictions really should not be based on the physiology, but rather the wisdom of the ethics of providing the care. And that reproduction, we believed, was a fundamental right in a free society, and therefore we shouldn't restrict it. We also understood that speculation about the risks involved was not necessarily a compelling enough reason to deny care, and that we should really rely, as academics, we were certainly trained this way, to make our decisions based upon the peer-reviewed data, which in 1990 didn't exist, and not use just politics or opinion to guide our decisions. So for literally almost 30 years since that time, I would get asked pretty much everywhere I went, and speaking on this topic so many times over the years, like, how old is too old, right? That's the question that always comes up. Should there be restrictions? And so when I was invited to speak at the pre-Congress meeting in 2018, among a very distinguished group of people, Dr. Zweifel was the organizer for this, but also Julia Woodward, Bob Rebar, and myself. It was a lively day, and it was very interesting to me because a lot of different opinions from a lot of different viewpoints. And we decided to publish the work from that day in JARG, which came out just about 2 months ago as a paper. And the summation of that paper, as well as that day in Denver, was that the different assisted reproductive technologies were increasingly being performed with people of older and older age. And I think all of us on this call tonight would know that is true. But the focus has largely been on outcomes, and the outcomes in the immediate sense, getting the woman to deliver safely, having a live-born baby, but very little follow-up of these patients, their children, or the families we're creating after that. And instead, we are pretty much relied upon a fairly biased media and press characterization of these sensational births, which are not necessarily very accurately portraying the reality of the families we're helping to create. And we also agreed during that day that we were unlikely to reach a consensus. It's just too much debate, but we certainly needed more open discussions on access and how to provide the care. The anecdotes continued to accumulate. After that paper was published, we were asked to be interviewed by a writer for the Washington Post who wanted to discuss whether or not these better fertility methods were impacting the offspring of these older parents. So in a Sunday Washington Post article, Eric Berger told his own story, having been born to older parents naturally, but then as an only child being relatively burdened by both aging parents with multiple health issues and losing his father ultimately when he was still a very young man, still is a young man, and how difficult that really is. And I thought it was a very compelling piece and spoke to this issue quite poignantly, that we need to think about the downstream, not just the immediate. What I thought was more interesting than his article itself was the comments that followed, and I read all 746 of them. It was fascinating. I didn't know what to expect. I was kind of holding my breath a little bit, but to sum it up, the great bulk were very critical of older parents, more in line with the lower panel. The only word I can think of is selfish, this particular person said. But there was a smattering of people, such as the one above, saying that, you know, older parents can do a good job, and that he was raised by his grandparents, and they were just, you know, it was great. So, you know, you're always going to have this kind of split decision among people that you ask. So really, what was the catalyst behind all this, and why was this such a phenomenon? And it basically is the human condition. I mean, forever, up until the very, very modern era, there really wasn't much alterations in how we as a species reproduce, right? So we were taught, it is still true, that the natural state is that by the time you're in your mid-30s and certainly 40s and 50s, reproduction is largely going to be extinguished as a natural act of aging. And this has also been detailed for hundreds of years by people that have kept records of natural populations where contraception was not practiced or sex was not prohibited during menstrual cycles. And you can see similarly the fall off in reproduction by your mid-30s and extinguished largely in your mid-40s. And that's the natural human state. The perfect storm in all this was the availability of accessible, affordable contraception that came in the 60s and 70s, along with legalized abortion, and a social change towards women having access and pursuing education and vocation so they can maintain autonomy in their lives and not be victimized by reproduction for those that are not seeking to have children. And along with later marriages and increased divorce, there's an increasing number of women who just age out of the natural reproductive paradigm. And this is very well demonstrated by looking at US natality during that same time frame, where around 1970 it completely plummets from the baby boomers when I was born, and has stayed low throughout as the social changes dictated by those events that I mentioned. Now, I think egg donation, embryo donation as well were the real disruptive innovations that made a significant impact on how we practice assisted reproduction today. I was very much involved in this both at UCLA and then USC in the late 80s in the early development of egg and embryo donation. We basically just extended it to different patient populations, including women who at the time were considered very much older at 40. It's hard for our young practitioners to realize in 1987, 1988, if you were over 35, in most good programs, you were denied care. So this was a game changer for those of us that decided to embrace it in taking on these older patients with no evidence basis for how safe it was going to be, but a fair amount of belief that it would work. And the first paper I published in 1990 in the New England Journal was truly disruptive innovation. I mean, it was a small series. In fact, I tell my residents and fellows over the years, this is a great example of how a small series of cases, basically a big case report, right, can change the practice of medicine if it happens to be true. So we had just a small handful of women and 5, pregnancies that delivered. But compared to women of their age, and they're all in their early 40s, it was remarkably improved. And so our conclusion didn't have to do with, look what we did, we made older women pregnant. It was more like, hey, endometrium retains its receptivity despite aging. And so perhaps older and older women can have children, but they need younger eggs to do that. It was a overnight sensation. I mean, all the news channels, every banner headline, you name it, picked the story up. Maybe it was a slow news day, I'm not sure, but it got tremendous coverage, and people literally from all over the world were headed towards Los Angeles to seek out care for pregnancy just related due to age-related changes. We therefore followed it up with increasing numbers of cases, and we published the follow-up paper 2 years later in JAMA, where I basically just extended it a little bit further now into the mid-50s. And what we found there again was the public really reacting, although this time a little more hesitant to embrace, because one of the patients who was profiled, a woman named Joni Mosby Mitchell, was a grandmother herself, and now with a second younger husband, was having for the first time a child with him at the exact same time that one of her daughters from her first marriage was having another grandchild for her. So it really confronting firsthand how old is too old, and people are doing things that are certainly not considered natural. What also went largely unnoticed, though, but not by me, because I enrolled every one of these women. I knew them well, and we were following them very closely, was how many complications we were witnessing. And you can see in this early series from JAMA, I mean, 76% C-section rate, gestational hypertensive. These were women who were well screened, had no history of blood pressure problems, and these unusual placental problems, 6 placenta previous in this first small series, 1 stillbirth. So we knew something was going on here, but it was still way too early to pass judgment, but we were a little concerned. The press just kept following the story, though. They love babies and they like controversy. So a whole piece in the LA Times dedicated to the work at USC came out right as I was leaving USC in 1995 to go to New York. And again, you see this dichotomy, a priceless possibility. I'm giving women, the chance to have children as in an older age, but critics say he's creating a generation of Medicare orphans. Now, at the time, I thought that was pretty harsh. Didn't really like the quote, but as time has shown, there's some truth to that. There have been a number of women that have died a few years or within a decade of giving birth to the children that were conceived using egg donation, and indeed these children who were orphaned by their older mother. The public, though, jumped on the story, and you can see it by just looking at birth rates in the country, both for the women over 45, particularly high linear increase, and also women over 50. So the story was out, the message was there. You can have a baby when you're older, and in a way sort of have it all. But that was kind of the simplistic view of it. Why did they jump on the method? Well, because it worked. I mean, nothing else was working, right? So we all know, and it's still true, and this is from 2006, but nothing has changed, that IVF certainly starts to fall off in success rates by your late 30s and early 40s, and it's extinguished usually by mid 40s, as egg donation just keeps on giving back. So the 50-50 chance of a pregnancy today is still very much true for egg donation, and because it works, people are going to access the care and demand it. So the widespread acceptance did encourage a certain amount of complacency within our peers and within the public. I think what was lost in all this was that motherhood is at any age is never risk-free, and that older motherhood is always high risk. I mean, without exception, no matter how hard people try to convince me that they're not high risk when they're 50, they are high risk. And we have tallied up over the years a number of these same complications that I mentioned earlier that Dr. Ralston's going to detail later in his talk, including stillbirths. So in summary, for the women, advanced maternal age is certainly still on the rise for women, largely because of assisted reproductive technology. They certainly experience more medical and obstetrical complications than their younger peers. And they also have a much higher mortality rate overall. As well as all the reproductive age risks associated with advancing age, including infertility, sterility, miscarriage, anomaly risk, obstetrical complications, and stillbirth. Some of these things are allayed by using young, eggs from a donor, but not all. Particularly the obstetrical complications and stillbirth problem is still a part of having a baby when you're older. What about the males? We did touch on it at great length, and I'll defer most of this discussion to the talks coming after me, but they've always been given a bit of a pass. Even the contemporary virility celebration, you saw Mick Jagger and Ron Wood of the Rolling Stones give birth a couple of years back. Not a lot of condemnation, but probably should have been questioned as to the wisdom of having children in your 70s if you're a male, because you're likely not to see them reach adulthood. Similar to what Anderson Cooper saw. And again, I just will touch on this, that it's an increasing common phenomenon with the older fathers. We know there's de novo mutations in sperm that give rise to rare syndromes and childhood hematopoietic cancers. There's increasing evidence about epigenetic risks for neurocognitive and metabolic disorders, including hypertension and diabetes. And then the psychiatric and neurodevelopmental disorders that Julianne Zweifel is going to talk about in a second. And last but not least, for both parents, but certainly true for the older fathers, they're probably more likely to die before the child reaches adulthood. So given all these risks and unknown, why are we continuing to offer these services, right? And the answer is simply that as a physician, the power of the individual requests they really are powerful. It's hard to say no, especially when they have compelling evidence that they are healthy, that their choice is well thought out. There's a tendency for all of us to appreciate and respect the autonomy of the patient's request. Araceli Kay, the 63-year-old that you saw earlier, who had her daughter back in, after I left, I was originally the physician that did her transfers, and later she ended up actually getting pregnant after I left, and was reported in '97, I believe. That's her daughter there. And Araceli Kay is interesting to me because she's actually the same age as my mother. And this young woman now, her daughter is in her mid-20s, and she's definitely dealing with a very geriatric mother and all the issues around that. Bob Edwards, though, should be remembered. He's the father of our field, and as he said so wisely in a foreword to my egg donation book years ago, we really must accept a fundamental truth here that virtually all of our patients are searching for happiness, and usually within the framework of the love for a child and a partner. And I think, again, that's what's made it hard to turn patients away with an arbitrary restriction on age. So whether you look at it historic or reckless, it's gone to extremes now, as you can see from some of the recent births in India, women literally in their early 70s continue to be challenged. Again, we should constantly be asking these same questions as to whether or not we should offer care to somebody in the extreme ages or not. So I will stop there and turn it over to Steve, and I'll be happy to take questions later at the end. Thank you all.
Thanks, Dr. Sauer. I wanted to introduce Dr. Stephen Ralston next. He is a professor of clinical OBGYN at the Perelman School of Medicine at the University of Pennsylvania. He is the chair of OBGYN at the Pennsylvania Hospital, where he practices as a maternal fetal medicine specialist. He has also served as the chair of the American College of OB-GYN Committee on Ethics, and is currently on that committee as the Society for Maternal Fetal Medicine liaison to this committee. I look forward to his insights from a high-risk perspective of pregnancy at advanced ages. Dr. Ralston?
Thank you so much, Dr. Klipstein. It's so great to be able to speak at this conference. I have one disclosure, and that's I became a parent for the first time at age 45, and preparing for this talk has made me quite depressed about the prospects for my children becoming orphaned at young ages, so I've had to rethink my will. So there's really only 5 questions that MFMs are ever asked to answer. Is my fetus healthy? Is it safe for me to stay pregnant? Should I have a vaginal delivery or cesarean section? Can I take this medication? And then the question that we're interested in, which is it safe for me and or my potential child for me to get pregnant? So will pregnancy be safe? And Mark has, I think, framed this for us very well in terms of maternal risks, and those could be morbidities or mortality, and then fetal risks, which are also morbidities and mortality. And the goal of the MFM consultation is to assess a patient's risk. We take a patient's history, we look at the epidemiology, we look at the literature, and then our job is to inform patients of these risks. And then we use shared decision-making to decide whether or not they should go forward with the pregnancy. And for shared decision-making, we have to see what her values are, what their goals are, what a couple's priorities are. And there are a few outcomes for the MFM consultation. The first outcome is that we may change a medication regimen to avoid teratogens. The second outcome may be to say, let's delay pregnancy for a little while so we can improve outcomes. You'll lose weight, you'll stop smoking, take this folic acid, get these vaccines. You've just had a cesarean section, let's wait a little while for it to heal. And maybe we should space out your pregnancies to improve outcomes. Or we may say, you're good to go. Let's proceed with an attempt at pregnancy. Your risks aren't that high and you should have a good outcome. But rarely, we will also say perhaps pregnancy should be avoided. And so how does parental age affect our counseling? For very young patients in their 20s and 30s, or patients in their 40s and 50s, how do we change our counseling based on parental age, either the mother's age or the potential father's age? Well, one of my mentors always said that good ethics require good facts. You need good information if you're going to make good decisions for patients and help them make good decisions for themselves. So what are the facts? What are the effects of maternal age? And Mark has just outlined some of them, that there are increased risks of everything that can go wrong in pregnancy is more likely to go wrong if you are older. And that ranges from mild things like hypertensive disorders and gestational diabetes to quite serious things like stroke, myocardial infarction, and of course death. And then the fetal risks, I don't have to tell this group that the risks of miscarriage are increased with maternal age, birth defects, especially trisomies, increase with age. And of course, there's risks of prematurity, which as a high-risk doctor, we worry about a lot. Because prematurity is not going to help a baby. It's going to lead to increased risk of neurologic outcomes that are bad or respiratory outcomes that are bad. IUGR is increased for older women, stillbirth and neonatal death, all increased for older women. And this is data from Mark's paper. If you just look at one of these things, cardiac arrest, it's 10 times more common in the age group over age 45. So, but the problem with that, of course, is that's a relative risk. And the absolute risk of all of these bad things happening is still pretty low because pregnancy is still a pretty safe thing for most women to do. So even though her relative risk may be increased for any of these outcomes, her absolute risk is still going to be not that high, depending on your perspective. And the real question is, whose perspective should we be using? Should we be using our perspective or the woman and the couple's perspective? I don't have to belabor the aneuploidy risks as women age, but these risks end up in the several percent range in women in their 40s if they're using their own eggs. But what about the potential father? What genetic risks is he adding to the equation? And I think you're all familiar with this data, that there are risks to the offspring from advanced paternal age. And how we define advanced paternal age varies from paper to paper. Sometimes it's 45, sometimes it's 50. But those are primarily risks of new autosomal dominant diseases because of the multiple mitoses that the sperm are going through. And we have examples in FGFR3 and FGFR2 leading to achondroplasia and the Cruzan-Pfeiffer and Apert syndromes. But the total risk for those new dominant disorders is probably no more than about 0.5%, even for very advanced paternal ages. And of course, there's more data coming out now of neuropsych disorders that are more common as fathers age, autism, schizophrenia. But of course, there are other genetic diseases that are in families that might confer much, much higher risks than those that are conferred by advanced paternal age. Here's a pedigree with an autosomal dominant disease. This might be Huntington's, this might be achondroplasia, this might be BRCA. And couples who have these genes in their families have a 50% chance of passing them on to their children. And that risk is usually not deemed to be too high to attempt ART for many of these disorders, especially if they're going to undergo pre-implantation genetic testing. So how do MFMs think about this? How do we think about these advanced maternal ages? Well, usually we have a few frames that we use in maternal fetal medicine. There's the frame of maternal autonomy and supporting patients in their choices. There's the frame of the maternal fetal dyad and trying to figure out what the interests of the mother and the fetus are, and they're almost always going to be in the same direction, that the fetus's interests are the interests of the mother staying healthy, and the mother's interests are in the mother staying healthy. And sometimes this maternal fetal dyad makes us think about women as they sit within their family structure and having interconnections with their family members, that having to make decisions that are beyond their own health and what the needs of their family is. And then, of course, there's the problematic frame of maternal obligation, what a good mother would do, what's best for her fetus. Would she do what's best for her family, or would she do what's best for her future child? And of course, there are problems with constructing motherhood as this sacrificial moment in women's lives, where what they are supposed to do is sacrifice their own health, their own needs, their own desires for those of their children and their family. So maybe MFMs should be the gatekeeper. Maybe we can't trust women to make these decisions for themselves, and so we have to make them for them. So what are we going to use as a cutoff for those risks? And so we have to have a threshold. How much risk is going to be too risk? When are we going to say this is too much and pregnancy is contraindicated? So there are going to be genetic diseases where we're going to say, well, the risk is quite high. Here's a family that has an autosomal recessive disease, and they've had 2 children that had this autosomal recessive disease, because that's what's going to happen with autosomal recessive diseases when both parents have the disease. Is it too much risk for them to have a 3rd child when we know 100% of the time the child's going to get this genetic disease? Will we participate in pregnancies, informing pregnancies that are going to lead to the birth of a genetically abnormal child? And maybe it depends on what that disease is. What are we going to do when we have embryos and one of the embryos is viable and it's an embryo that we know is going to lead to a child being born with trisomy 21? Are we going to allow that child to be born? Are we going to help that child be born? And of course, classically, we teach in maternal fetal medicine in our fellowships and in residency that there are some maternal diseases for which pregnancy is contraindicated. Marfan's disease, pulmonary hypertension, with mortality ranges in the 25 to 50% range. And typically, if we're going to recommend pregnancy termination or avoiding pregnancy altogether, these outcomes have to be serious, they have to be predictable, and they have to be pretty likely. And again, most of the outcomes that we've talked about for women are not that high in likelihood of 25 to 50%. Relative risks are higher, but absolute risks not that high. So the ethical tension is always going to be about whether we're going to support parental autonomy and reproductive freedom, or are we going to do what's in the best interest of the child? And that, of course, is another thorny issue for us, is what is in the best interest of the child? Is it to have the best possible parents, to have good enough parents, to have parents that are going to survive at least until maturity? Or is it in the best interest of the child to exist at all? Because remember, if we don't help these patients get pregnant, then those children will never exist. So I, of course, are going to come down on the side of parents making these decisions, because ultimately they have to take on the burdens. But not all decisions are going to be perfect. Here's what the horrible thing that I did to my son. But ART clinics are going to have to make some hard decisions. And there is a difference between saying that this care is allowable and saying that every single IVF clinic has to participate in this care. And so there may be IVF clinics that don't want to participate in the care of women who are over the age of 50 or 55 or whatever cutoff they're going to use. And I think the goal is to avoid discrimination that's going to be unjust. And not to say that people aren't going to make good parents because they are too blank or not blank enough, or that you don't want to treat blank patients, but to say that this is too risky for us to participate in. And I think that you can be an ethical IVF provider and say that. So the job for me is to give information. And if people have information and they have it in enough volume and depth to make good decisions, then we should trust them to make those decisions for themselves. So in conclusion, cutoffs might be bad. It might be paternalistic for us to make decisions for patients. It's not patient-centered. It doesn't promote reproductive liberty, and it perpetuates a narrow view of what an acceptable family structure is for children. We think that these parents are too old to have children, and yet we don't know what their plans are for that child. We don't know what family structure they have. We don't know what support systems they have. We don't know what village they have planned for their children. And of course, it perpetuates sexist views because older mothers are seen very differently from older fathers. And of course, it perpetuates ageist views that just old people can't do this. But it may be that these cutoffs have some good to them. First of all, they are concrete and they are transparent. If you put up a sign that says, we don't take women over the age 50, you don't take women over the age 50, and everybody knows that. And you may be decreasing some harms to some women and some babies and children. And I think the task for the IVF clinics is to use a framework that is applied equitably and transparently. Then the age cutoffs are not necessarily unethical. You use them all the time when you're deciding around for futility for ART with donor eggs, without donor eggs. Please use MFM. We're happy to counsel patients, but don't expect us to say that pregnancy is contraindicated if it's not, because it usually isn't. And please use as many support counselors as you can to help guide patients into making good decisions for themselves, to make sure that they have the family structure, the supports, and the childcare that they're going to need, especially if they're older and they might die. And then the few questions that might keep you up at night, because they keep me up at night, what are you going to do with stored embryos, especially when parents age out and you're not going to use them anymore in your clinic? And how do you approach potential patients who are not old, but who have decreased life expectancy due to illness, whether they have cancer? Maybe you're going to want to say that at least one parent has a blank % chance of surviving until the child reaches age blank. And how does our analysis change if it's a single parent? So that's a lot. I know I haven't answered every single question that you might have, and really my goal in giving a talk like that is to make sure you think about these things clearly and use a frame and an analysis that's going to lead you into a good direction.
Thank you, Dr. Ralston. Fascinating talk. And to get the third perspective, I wanted to introduce Dr. Julianne Zweifel, who has a PhD in clinical psychology. She's a clinical assistant professor at the Department of Obstetrics and Gynecology at the University of Wisconsin. Dr. Zweifel is recognized by the National Register of Health Service Providers in Psychology. She is a member of the Ethics Committee of the American Society for Reproductive Medicine. Dr. Zweifel's area of expertise is working with individuals and couples facing reproductive health issues, including infertility, high-risk pregnancies, multiple gestation, miscarriage, and infant death. Her research interests include psychological aspects of egg donation, decision-making processes for patients in infertility, and the role of stress in infertility. So Dr. Zweifel, I introduce you. Looking forward to hearing your perspective.
Thanks very much. I have nothing to disclose. So I really want to frame this in the fact that parents may assume risks for a child. However, we as clinicians have a moral responsibility to ensure that reproductive choices being made are considering the well-being and the welfare of the resulting children. So many people remark that older parents make better parents, that they're more mature, they have better resources, and there may be some truth to this. If we look at IQ scores, it's a mixed bag though. So what you see here are IQ scores using the Stanford Binet, and this was a study that looked at kids and they were had their IQs assessed multiple times across the years. And what you see is that if your mother is getting up towards the 30s and in the 40s, the IQs for those kids seem to be higher than if the mother was in the 20s. So there is an association with increased IQ with children when the maternal age is increasing up to age 45 is where that study went. However, the reverse is true for paternal age. IQ was decreasing. Here's another study that it takes a slightly different look at things. So this is a study that looked at specifically the sons of older dads. And what they found was there was a subset of these boys who scored high on something they called the geek index. These kids had high nonverbal IQs. They had restricted interests, and they were a little bit socially aloof, not too interested in peers. And so what we saw here was that these kids tended to take more STEM classes, which is sort of fits this idea of the geek. And the speculation is kids who take STEM classes are going to end up in higher paying careers. And so the idea then, if you add all this together, is older dads result in kids taking STEM classes and higher wage earners. There's also an idea that older parents are kinder, they're more mature, more emotionally available. So this is a study of moms and their 3-year-olds. What you see here is that the parent-child conflict does seem to decrease as you had increasing maternal age, and negative parenting is decreasing. However, what you see is parental supportiveness and positive parenting really kind of peaks in the mid to later 30s and then begins to drop off. Also, the home learning environment and household chaos also more optimal at about age 30, and then begins to have an unhelpful trend with increasing age. So it's not really clear that older parents are more warm and nurturing overall once you get past the 30s. Now, there are a lot of disadvantages for children of older parents, and I'm not going to be able to get into all of them, but I'm going to touch on a few. So mental health diagnoses are definitely increased with older parents. So this is a huge study. What you see here is 2.5 million kids in Sweden. And what these authors did was they compared outcomes to children of fathers who were 45 years old or older. And the reference group is dads who are 20 to 24. And you can see for yourself that everything there is an increased risk with the older group. Some of those risks really substantially elevated. What they also found was that they had a dose response within families, meaning that they looked at siblings from the same father, and that the siblings born later to the same father were more likely to show each of these diagnoses or problem areas compared to the siblings who were born earlier in the father's life. From more of an emotional and psychological experience, interviews with kids demonstrate that kids are really aware of their parents' age, and there's some social embarrassment about that, and they're really fearful of parental death. Fear of parental death is a super common fear, but it is more prevalent with children whose parents are older. And those kids really are paying attention to their parents' health, and they are aware. They understand that their parents are going to die earlier in their life. They are often only children, and ironically, after they have this experience, they indicate that they want to start having children earlier in their life. They do not want to be older parents. They want to be younger. So this is an interesting study that interviewed offspring up to age 25 who had parents of different age groups, and they asked them, how old do you wish your parents had been at the time you were born? And what you see here is in terms of mothers, if you look at that 30 to 34-year-old bracket of bars on our bar chart, that once the moms hit the 30 to 34-year-old age bracket for time at age at birth, that the kids, more than half of them, more than 60%, wished that their moms had been younger when they were born. And of course, that percentage increases. And we see the same type of data for dads. Once they hit that 30 to 34-year-old range, that's when the kids wish that their parents had been younger when they had them. And if you look at our last bar, if the dads are 50 or above, all of those offspring wish their dad had been younger. And it's not just the kids who are having a hard time with it. Once these parents do have kids, they talk about feeling like they don't fit in. They feel conspicuous. But the biggest thing that I'm concerned about personally is the fact that there's very few shared life years, and that the parents are going to die earlier in the child's life. And I think that this is a really critical point, because all the things we talk about, health risks of pregnancy and genetic issues, you can really get around that by using donor egg, donor sperm, gestational carrier. But what you can't get around, no matter what you do, is the fact that older parents are going to die earlier in their child's life. This is a letter from Benjamin Franklin to his friend John Allen, who had just gotten married. And what he says is he wants his friend to get going on having kids because late children are early orphans. So this is data from the National Life Tables, and it's formatted in a way that you can see in the blue column the probability that a father will die by the time his child is 5, 10, 15, or 20 years of age, according to our rows, which are the ages. If you look at the leftmost column, the age at which the father, how old he was when the child was born. And if we just look at the row of 50, when the dad is 50 years old, what you see is there's a greater than 13% chance that he's going to die by the time the child is 15 and possibly earlier. And there's a greater than 20% chance that he's going to die by the time that child is 20 or earlier. And of course, the numbers go up. 55, we're starting to get up close to 20% chance that he's going to die by the time the child's 15, and we're approaching 30% chance that he's going to die by the time the child's 20. Okay, and so here we see the same data for mothers. Of course, the numbers are a little bit different, but certainly the trend is the same. So if we look at women who are 50 years old at the time their child is born, there's a 13.5% chance they're going to die by the time their child is 20, and they may die earlier. Once we get up to 55, we're approaching 12% chance that they're going to die by the time their child's 15, and nearly 20% by the time their child is 20. And as Art Kaplan has said, it's not good public policy to make orphans. What's interesting to me is that having your parents die early in your life actually has a health consequence for you. So exposure to early parental death by the age of 15 increases the mortality risk in offspring. So having a parent die between when you are 5 to 17 has the greatest significant impact in terms of offspring longevity. However, if you have older parents and they live till the child is 35, it doesn't have a negative impact on longevity. At least that's what the research seems to suggest. I know this is a super busy slide. I want to call our attention to the two groupings of bar charts on the far right. So what this does is it looks at how old a child was at the time their parent died and the mortality risk ratio, and it's stratified in terms along the x-axis of time since the death of the parent. So if we look at 15 to 18 years out and 19 plus years out, what we see is there's a really significant increase in mortality risk. And what I find fascinating is it's the kids who lost a parent when they were 11 to 14 years old or 15 to 18 years old that have the highest risk. And you might think, well, but they got the most time with their parents, wouldn't that be protective? And I would say, no, I don't think so, because I think that they ended up needing to care for their parent and they were acutely aware of the risk, whereas the younger kids probably just weren't as aware. So I'm just going to let you see this. There's a lot of psychological problems for bereaved children, a lot of diagnoses and trouble, but basically it's the end of childhood, and I think it goes back to that quote by Anderson Cooper that Mark talked about. So grieving children lose a lot of things. They often have to move in with somebody else. They lose their home. They lose their familiar objects. They may lose their pet. Their remaining parent is often grieving and less emotionally available, and they're frightened of losing their next parent. And it's described as a loss of innocence. Now, many people I talk to say, I'm only 50 years old, I got a lot of life left. But if you are 50 years old, you may have a number of life years left, but the question to me really is, how many healthy life years do you have? And you can see it's less. So these children that are taking care of their parents might be quite young. So we really have children taking care of older parents. And there are a lot of risks for children taking care of parents. First of all, it's just hard to live a normal child life. It's hard to really have time for school and homework. Kids are more likely to drop out. They certainly less time available to participate in normal activities that their friends would, less time for friends themselves. They're also afraid of finding their parent dead. And it's also agonizing to watch their parent decline and be ill. Ironically, even though children of older parents want to have kids earlier than their parents did, oftentimes, consequentially, they need to postpone it because they feel they need to stay home and not leave for college, take care of their parents. So there's a postponement of these life goals, and their own parenting gets pushed off. So children of older parents wish their parents had had them earlier. They'd like to have their own kids earlier. But there are a lot of life consequences. So if you have to push off your own parenting, you may actually experience infertility. So ironically, the reproductive autonomy of one generation robs the right to autonomy of another. So children of older parents, maybe they're doing better intellectually, but I'm not sure that that's really what that data suggests. But the real big interest to me is the fact that these kids are facing fewer life years with their parents, no matter how the reproductive strategy carries out. And I think it has profound impact. Thank you.
Thank you so much. And we'll open it now to questions. We have quite a few, and so we may go over the hour just by a few minutes. The first question is for Mark. One of the viewers wanted to know, did the initial studies have an upper age limit, and would you have agreed to help women in their 60s or their 70s when you were initially looking at this?
Yes, remember that when we began this work at USC, it was under approval of IRB, and as all IRBs done on a clinical study, you need an upper age limit cutoffs and exclusion criteria. So the original was for cutoff was 45. After the New England Journal paper was published, we extended it to 55. The reason Araceli K, the 63-year-old, got into that cohort was because as many later, she misrepresented her age in order to get treated. So at 63, she had presented herself at 53. And I've seen patients over the years that we have treated well into their 60s who had false passports, all kinds of things in order to try to gain entrance to care. So one of the messages is whenever you have a cutoff, expect people to trespass and to find a way to get around it. But we did have cutoffs, and some of the older births were results of people literally purposefully trespassing over the cutoffs.
Thank you. For Julianne, do these studies take into account specific data regarding the prospective father's familial health? And do you suggest that people who have various health issues should not have children at any age? And then I think I would ask the same question of Stephen.
So some of those studies are just huge population studies where the data was collected in Sweden, Finland, and Denmark, and so they just basically took. I mean, they're huge. So I don't think it says in the study whether they drilled down. I don't know that they had that data. And in terms of people with limited lifespans due to illness, to me the critical difference here is that with illness, at least with some illnesses, there is a potential for treating those illnesses, not necessarily with that patient, but over time, research has proven to be able to be effective in really helping people with illness prolong their lives in a very meaningful way and in a healthy way. Whereas I would argue aging is aging, and we will never get around it. And it's not just a physical issue, it is a psychological and social relationship issue.
Mark, using a gestational carrier circumvents many of the maternal fetal risks. How does the availability of a gestational carrier affect your thinking?
Good question. I think I've changed along those lines. In the sense of, again, the concern about parenting and longevity, all the issues that Julianne mentioned, I think are very pertinent and need to be discussed. And I've seen this where single parents, single individual want to have a child at very advanced stages, and it's clear, no matter how healthy they are, that they're just not going to be able to raise this child. Commonly, what happens in those kind of cases, by the way, is that their support systems are also older, and so they're a little bit flawed in the logic. So we do take the child into consideration, and I think that's where you have to look at the gestational carrier request.
Thank you. There's another question. Do the same considerations hold true for surrogates, particularly older mothers who carry for their daughters? Do you think that's a different situation?
Yeah, so this comes up not infrequently, that we will have a patient that we will say, we think that you will have a much better pregnancy outcome if you use a gestational carrier. Somebody who has had multiple periviable births, for example, where we think that their ability to carry a pregnancy beyond 24, 25 weeks may be quite limited. A gestational carrier is always going to be better for them. But it's never going to change the question of whether or not a patient is too old to parent. Yes, pregnancy outcomes will often be better if we use a gestational carrier, but often that is financially not achievable, or it's ethically not tenable for patients, or certainly outside of the United States, it just might not be legal.
Thank you. Julianne, this is a question that came up. Do you think it's important for REIs to learn about the significant risks to children?
Yeah, I think Mark caught this point in his talk when he said that it's easy to approach this as a really narrow focus, and if you're just, or maybe it was Stephen, if you're just looking at the health outcome, like our ability to get people pregnant, our ability to have them be able to carry to term and have at least reasonably good initial infant health, I would argue that scope, that lens is too narrow, because that child's going to be around. And so, yeah, I think we need to help everybody who's contributing to these decisions to broaden their perspective. I often feel like on the team, the treatment team, that's a little bit of my job is to represent the person who's not there. You know, Mark said it's hard to say no to patients, but it's also hard because you don't have a child there saying, if this happens, I will have this life experience. If that happens, I will have this life experience. There's nobody that the child, because they don't exist, can't advocate. So I hope that answers the question.
Yeah, and Julianne, I have a different question also for you. What about cultural variations in families where extended family are involved in raising the children? So while they may lose an older parent, extended family will continue to raise the children? Is that different?
So, I mean, I think that making sure that there are people who are going to be responsible for your child is essential. I also think it can be really nice and wonderful for a child if the people who take over rearing them are people that they grew up knowing, you know, and that may not be the case. You know, they may have met them, but maybe they live states away. And again, that means that those kids are moving. They're moving school systems, and, you know, a disruption beyond just losing a parent, which is, you know, the biggest part. But I don't think that takes away the impact of losing a parent. It's great if you have people who love you, but that doesn't take away what it's like to lose a parent or lose both your parents. That's still going to be there.
Thank you. There's another question, I think, for Mark. What cutoff age policies have you seen at fertility clinics in terms of gestational carriers? 50, 55 combined age for the couple. So I assume this is the younger gestational carrier for an older couple.
Right, and again, there's a lot of variations. I've not seen any good evidence basis for what the real standard of practice is out there. In my own experience, whether it was at, you know, you're now at RMA, also UCSF. I mean, each program has very different approaches to these questions. I wanted to say one thing that Steve was saying. You know, you do get asked by mothers to carry the embryos of their daughters, and that's a tricky one too, because the mothers are obviously older, and a younger gestational carrier would be a better biologic choice. But you have to also address the personal family side to this and the intimacy of families in these decisions. And again, it makes it very complicated. It really requires, no matter what, as everybody has said tonight, a real interdisciplinary approach. You need multiple experts working on these cases in obstetrics and reproductive medicine and in psychology, psychiatry. So that would be my real big message about every one of these scenarios that people are asking about, is don't be afraid to consult and work outside the practice to get the right decision for what you need to make, you know, to make the right decision, to get the right information.
Thank you. There's another question I'll address to all three of you, and it asks, do we have any research to suggest that a child born of older parents would have preferred not to be born? I'm not sure there's any data on that, but do any of you want to weigh in on that? Kind of the impossible question.
There's actually quite a bit of data on people with disabilities and how they rate their lives and how they evaluate their life prospects and their capabilities for joy, happiness, etc. And my reading of that data is that we as clinicians always underestimate how happy people with disabilities might be. And people with disabilities are probably much happier than we think that they are. And so I think of this as a similar kind of class of people, that they may decide that their lives are not perfect and they would wish that their parents were younger and they would wish that their parents hadn't died, but that they probably don't wish that they had never been born. But I don't think we have empiric data to tell us that. Maybe Julianne, you know better.
I'll jump in. We don't have empiric data. Like this is a really hard area to study because there aren't enough. It's hard to collect your subjects in order to get them to answer that. There are studies where people have discussed this, and some very few people will say that. However, one of the things that I feel is that setting the bar, and I'm not saying that whoever wrote the question is saying this, but many people will say unless the child wishes they'd never been born, then their circumstances of being born is an advantage to them. And so even though it's maybe a tough road, it's still an advantage because they were born. And I like to point out that I don't think we hold that bar to other people and the concerns that they have in life, that you have to wish you had never been born in order for your concern to have merit. And the other thing, I can't remember the ethicist that said this, but I've got a quote somewhere in a different set of slides where the person says, you know, making the point that that we would be preventing children from being born is only of merit if we think that there's a collection of people somewhere waiting to be born and we're preventing them. And there isn't. So, you know, if the child hadn't been born, the child hadn't been born, and they wouldn't be here to complain either. So I have trouble with that limitation of the concerns.
I'll just say one thing quickly. To me, the problem with all these anecdotes is just that. It's not really valid in any kind of evidence-based way. I mean, you can always find either a romanticized view of how great a person's life is, and life tends to be long no matter how old your parents are, or a condemnation, again, of having, you know, kind of a miserable life. I think, anecdotal as it is, I have rarely heard from any of my patients over 30 years' time that have either the children or siblings or the mother herself or the father said, boy, what a mistake this was. I wish I would have never done this. I can't believe you should know what a mistake it was for you to have done this. Not one time. And I think if there was something going on out there that was really sinister that way, I think by now I would be at least aware of some examples of that. I just have not seen it, not one time.
Thank you. There was one comment, which I don't think is exactly a question, but legally, what's the basis to advance the rights of an unborn child over the choices of the parents to have children? So who gets to decide, in the sense the child can't decide not to be born? There's another question. When is reproductive autonomy just denial on the part of the intended parents in terms of thinking they can do something that perhaps is not reasonable for them? And maybe, Stephen, do you want to answer that? You see a lot of preconceptual counseling. Are there situations in which you feel that the intended parents don't have a good understanding of the risks involved?
Of course, after my perfect counseling, patients always understand the risks perfectly. But I think that's a really hard thing to know, Sagal. Like we ask patients to sort of tell us what their understanding is of what we've said to them. And we hope that they are going to at least parrot back the data that we've given them. But do they comprehend it? Like, they may apprehend the data, but do they comprehend it? Does it really sink in and make sense to them in sort of what their world is? There have been a handful of patients that I've had over the years where I've said to them, I know you want to get pregnant, but I think that this is a really bad idea for you for the following reasons. And they say, I understand you, doctor, but this is very important to me, and so we're going forward with this. So I do think that most patients are capable of understanding this, but whether they are going to understand it in that deep way that we want them to understand it, I'm not sure.
Yeah, and I think there's such a strong bias of patients who we actually do see. I mean, they've gone through a lot of soul searching typically before they ever come in to see us. And again, you can present them a lot of good objective information and give them all kinds of warnings. But just as Steve said, they're usually going to come back, listen, I get it, but it's my life and I'm willing to take that risk and it's going to be fine. And again, at that point, it just becomes a paternalistic, we're not doing it if that's the case. And I think that's the problem I have with drawing firm lines of you can't trespass across, because I've seen too many exceptions to those kind of rules.
So I'll jump in and I'll say that, so there is a small study that looked at older parents, and once they have their children, that's when all that information that the MFMs have been talking about in terms of life and health risks and stuff that I was talking about in terms of longevity, that's when it hits them like a ton of bricks. I think that when they're trying to have a child, that information is held at arm's length. And I think that that's a psychological strategy because they're prioritizing their goal for having a child. Once that child is there, I really think things get shuffled around a lot differently, and they are concerned. They may not be coming back into their physician's office and saying, I'm sorry, I made a mistake, but they are reporting, some of them, I mean, there's a study on this, that they feel they should have had their child earlier, and they're talking about having had they'll say in their later 30s rather than in their later 40s.
Of course, the other question I suppose that might help answer that question is how many parents of advanced age then come back for a second child after they've had the first, because of course nobody can really tell what it's like to be a parent until you've been a parent. But do you see sorry, that's on my end, Sandra. Do you see a lot of people who come back for second children, or do you feel that perhaps once you have your first child at an advanced age, you might not then further pursue pregnancy?
I think it depends on how sorry, go ahead.
That's a really good question. You know, I can't say that I've seen too many. It depends a little bit on the age they came in to begin with. Remember that in the beginning of all this, if you were over 40, that was pretty old. And so I certainly saw a few people that we treated early on between 40 and 45 that came back for a subsequent sibling. And that was always the plan. But after 50, not so much. I'm sure there over the years there might have been one, but I have to think real hard about it. It usually was a one-shot deal.
Yeah, Mark, what I was going to say, I think it completely depends on what the outcome was for that first pregnancy. And if you have a 48-year-old that has a easy pregnancy, then she's going to think she's going to have an easy pregnancy at 50 when she comes back. And so I've seen several patients like that.
So this will be just our last question, and I said it to all the panelists. The audience really wants to know, after all of your research and investigation, what is the upper limit for having a baby? Have we done our job?
I'll start with that. I'll say it's sort of what I did with the beginning of my talk. I still don't know really what that would be. I get increasingly uncomfortable after 55. I've had way too many good outcomes in women under 55. So again, I think you have to weigh what the patient brings to you as an individual request and your own comfort zone, and make your own decisions on each individual ask.
I'll jump in next, and I'll say I think we can't. I approach this very differently. I don't think we can do this on an individual basis unless there's increased health risks that make somebody a special case. I think we need to be consistent across patients. I think we need to be consistent across men and women. And I purposefully, when I was going through those life tables, was highlighting the age of 50, because that's where I think when we're talking about the risk of somebody dying, losing your parent, approaching 15% by the time you're 15 years old and 20% by the time you're 20. I mean, that's a big risk. And so I think it's very reasonable. I think you can frame it back in Mark's slide of when did people really stop having kids naturally. It happened then. And I know that we push the medical limits on things. And so it's not really quite my point, but you can't kind of keep kicking the can down the road and having kids later and later and recognizing you're going to have fewer and fewer life years with that child. It has a consequence for them. So I would say 50.
Stephen, do you want to take the last word on this one?
Yeah, so I absolutely agree with Julianne that we cannot do this case by case, because we will inevitably allow bias into our decision making. We'll say, well, this 50-year-old we think is going to be a good parent because of X, Y, and Z. This 50-year-old is not as good a candidate. I certainly, as an MFM, start looking for reasons to dissuade women from becoming pregnant after age 50. I start doing large metabolic panels on them. I do echoes. I may even recommend a stress test if there's anything on their EKG that's unusual, because I want to make sure that they have nothing. And I'm actually looking for things to say to them, listen, I think you're the wrong candidate for this plan. But I have trouble putting a line in the sand and saying that above this, you can't do this. You can't have access to this human experience. But I will say, from a personal standpoint, I adopted my first child at age 45. I adopted my second child at age 47. And I pray to God every day at age 57 that those birth mothers do not have more children and come knocking on my door, because I'm too old now.
Thank you. All right, thank you very much. This concludes the webinar, and I believe, Sarah, do you have some closing statements?
Yes, thank you, Dr. Clipstein, for moderating this session. Thank you to our panelists for the insightful talk while jumping over some technical glitches. To our attendees, thank you for joining us, and we enjoyed your questions. You will receive a survey by email after this session. Your feedback helps us give you the most relevant content, and your input is appreciated. This session was recorded and will be available on our website in the near future. Please watch your email for notification about future webinars. For any further questions or comments, please don't hesitate to contact us at webinars@asrm.org. This concludes the webinar.